This voiceover is part 1 of the pain lecture. We will be considering the pain pathways, since understanding these provides a foundation for understanding pharmacological treatment of pain. We will also be discussing pain assessment and selected non-pharmacological therapies. Now, I need to acknowledge that many of these slides are from SlideShare, and they were created by Meghana Devolapalli. First, we need to have a definition of pain, and I have 3 of them. Pain is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Or, pain is an unpleasant subjective experience that is the net effect of a complex interaction of the ascending and descending nervous systems involving biochemical, physiologic, psychological, and neurocortical processes. Also, McCaffrey, a nurse, defined pain as whatever the person experiencing the pain says it is, existing whenever the person says it does. Now, the epidemiology of pain is significant. According to the American Pain Foundation, more than 50 million people in the United States suffer from chronic pain. An additional 25%, or 20 million, experience acute pain from injury or surgery. The annual incidence of moderate intensity back pain is 10 to 15% in the adult population, with a point prevalence of 15 to 30%. The National Institute for Occupational Safety and Health estimated that the cost of low back pain alone was between 50 billion to 100 billion per year. Now, there are several classifications of pain, and one of which is the following. It is based on source, location, referral, and duration. On the left-hand side is acute or traumatic pain that can be broken down into visceral pain or somatic pain, and superficial pain or deep somatic pain. On the right-hand side is chronic pain, which can be broken down into malignant pain or cancer pain, non-malignant pain or benign pain, musculoskeletal pain, and neuropathic pain, and we're going to look at each of these. Acute pain has a sudden onset, usually subsides quickly, and is characterized by a sharp, localized sensation with an identifiable cause. It lasts less than 30 days and occurs after muscle strains and tissue injury, such as trauma or surgery, and is described as a linear process. Poorly treated pain can cause psychological stress and compromise the immune system due to the release of endogenous corticosteroids. Acute pain is usually characterized by increased autonomic nervous system activity, resulting in psychological symptoms such as anxiety, tachypnea, tachycardia with hypertension, pallor, diaphoresis, and pupil dilation. Visceral pain, on the other hand, is the type of nociceptive pain that comes from the internal organs. Unlike somatic pain, it is harder to pinpoint. Pain is described as general aching or squeezing. It is caused by the activation of pain receptors in the chest, abdomen, or pelvic areas. In cancer pain, pain is caused by tumor infiltration, constipation, radiation, and chemotherapy. Now, superficial pain is also known as cutaneous pain. It arises from superficial structures such as skin and subcutaneous tissues. It is a sharp, bright pain with a burning quality and may be abrupt or slow in onset. On the opposite end, deep somatic pain originates deep in body structures such as the periosteum, muscles, tendons, joint, and blood vessels. Strong pressure, ischemia, and tissue damage act as stimuli, and the pain can radiate from the original site of the injury. Now, chronic pain is arbitrarily defined as pain lasting longer than 3 to 6 months. It begins when pain persists after the initial injury has healed. It is persistent or episodic pain of duration or intensity that adversely affects function and well-being of the patient. It may be nociceptive, inflammatory, neuropathic, or functional in origin. It varies from unrelenting, extremely severe pain to pain of escalating or non-escalating nature. Now, the main effects of chronic pain are the effect on physical function. For example, there may be a decreased ability to do activities of daily living. There also may be psychological changes, for instance, anxiety and depression. Social consequences can be seclusion or isolation, and societal complications are the cost of the disease and decrease in productivity. Now, chronic malignant pain occurs in 60 to 90% of patients with cancer. The pain can be related to the tumor or the cancer therapy, or it may be idiosyncratic. Pain may also be found at the metastasized regions, and treatment interventions may activate peripheral nociceptors. Pain can be somatic or visceral. Chronic non-cancer pain is also referred to as chronic non-malignant pain. This pain may last for many years and be considered progressive in nature. It may be nociceptive, neuropathic, or mixed. Now, neuropathic pain is a result of an injury or malfunction of the nervous system. It is described as aching, throbbing, burning, shooting, stinging, or tenderness and sensitivity of the skin. Mechanisms of neuropathic pain include nerve damage or persistent stimulation that results in a rewiring of those pain circuits, both anatomically and biochemically, which causes spontaneous nerve stimulation, autonomic neuronal stimulation, and increased discharge of dorsal horn neurons, finally leading to neuropathic pain. Musculoskeletal pain is a type of chronic non-cancer pain occurring due to musculoskeletal disorders such as rheumatoid arthritis, osteoarthritis, fibromyalgia, and peripheral neuropathies. Other types of pain are referred pain, which is pain that is perceived at the site different from its point of origin but innervated by the same spinal segment. It usually applies to pain that originates from the viscera. For example, pain associated with MI commonly is referred to the left arm, neck, and chest. Breakthrough pain is intermittent, transitory, and an increase in pain that occurs at greater intensity. It usually lasts from minutes to hours and can interfere with functioning and quality of life. For example, neuropathic pain or lower back pain. Now, these are some of the areas of common referred pain. You can see where the heart is into the chest and the esophagus. Those are the areas where the stomach refers to, the liver and the gallbladder, etc. Now, pain receptors or nociceptors are sensory receptors that are activated by noxious insult to the peripheral tissues. The receptive endings of the peripheral pain fibers are free nerve endings. These receptive endings are widely distributed in the skin, dental pulp, periosteum, and the meninges. Now I want to look a second at the nerve fibers involved in pain transmission. The A beta fibers are a subcategory of A fibers. They are large, myelinated, fast-conducting, low stimulation threshold, and respond to light touch. The A delta fibers are small, lightly myelinated, slow conducting, respond to heat, pressure, cooling, and chemicals, and they provide the sharp sensation of pain. The C fibers are small and unmyelinated. They're very slow conducting, respond to all types of noxious stimuli, and transmit prolonged dull pain. They require high-intensity stimuli to trigger a response. So keeping this in mind, we're going to look at it as it relates to mechanisms of pain. Pain sensation involves a series of complex interactions between peripheral nerves and the central nervous system. Pain sensation is modulated by excitatory and inhibitory neurotransmitters released in response to stimuli. The sensation of pain is composed of four basic processes: transduction, transmission, modulation, and perception. Now, in transduction, the C fibers and the A delta fibers are depolarized by noxious mechanical, thermal, or chemical energy. Substances released include substance P, ATP, bradykinin, and prostaglandins. These are going to become important when we talk about the pharmacological interventions in part 2 of this lecture. Nociceptive terminals are found in the periosteum, joints, tendons, muscles, and skin. They have a high threshold and require intense stimulation, but can be made more sensitive through neurotransmitters such as bradykinin, which leads to something called hyperesthesia. Now, transmission occurs after the stimulation of the nociceptors in the skin, and a signal is sent up a nerve fiber, which is a first-order neuron, and those are the C and A delta fibers. It reaches the spinal cord in the dorsal horn and is passed to another neuron, or a second-order neuron, via chemical mediators to the brain. And excitatory neurotransmitters are released in that dorsal horn, which includes glutamate, aspartate, and substance P. But there's also inhibitory neurotransmitters such as GABA, serotonin, and norepinephrine. In the brain, the signal goes to the thalamus, which sorts and sends it to a third-degree neuron in the somatosensory cortex, which you get physical sensation. In the frontal cortex, which you have logical responses to pain or meaning of the pain, and to the limbic system, which is involved in the emotional response to pain. Now, modulation occurs because there are pathways that arise in the midbrain and brainstem and descend to the spinal cord and modulate pain impulses. For example, in the midbrain there is an area, the para-aqueductal gray, or the PAG. It receives input from many areas in the brain and is connected to an area in the medulla, which is the nucleus raphe magnus, or the NRM. That projects into the dorsal horn of the spinal cord, where they terminate close to where the pain fibers enter. Stimulation of the NRM can block pain. There are many ways pain can be modulated or inhibited through the PAG, and these include endogenous endorphins and other chemicals that can inhibit pain transmission, including serotonin, norepinephrine, and GABA. Now, there are several pain theories, but we're only going to look at this one, which is the gate control mechanism. This was proposed by Melzack and Wall in 1965. According to this theory, the pain stimuli transmitted by afferent pain fibers are blocked by a gate mechanism located in the posterior gray horn of the spinal cord. If the gate is open, pain is felt. If the gate is closed, pain is suppressed. Impulses from A alpha and C fibers can be blocked and modulated by AB activity that can selectively block impulses from being transmitted to the transmission cells in the spinal cord and to the CNS, resulting in no pain. So the role of the brain in the gate control mechanism: gates in the spinal cord are open, pain signals reach the thalamus through the lateral spinal thalamic tract, signals are processed in the thalamus, and signals are sent to the sensory cortex, and perception of pain occurs in that cortex. Signals are sent from the cortex back to the spinal cord, and the gate is closed by releasing pain relievers such as opioid peptides, and these minimize the severity and extent of pain. Now we want to look at the assessment of pain, and this includes several things. One is a comprehensive history intake: medical history, physical history, and family history. A physical exam and a questioning about the characteristic of pain: onset, duration, location, quality, severity, and intensity, and also an evaluation of the psychological status. Now there are several pain assessment mnemonics, but I chose this one, the PQRST, and the first is palliative. You have to ask the patient what makes the pain better, what makes it worse, or what causes it. Also, the quality of it: is it sharp, shooting, burning, deep, aching, all helping identify the type of pain, which will help in deciding which intervention is appropriate. Also want to know about the radiation in the region. Where is the pain located, and does it radiate? The severity: we want to know the pain intensity, and I'm sure you're all familiar with the pain scales. And the time: to describe the pain as steady, intermittent, or transient. And you're also going to need to know when it started and how long it has lasted. And furthermore, the impact of pain on the patient's functional status, behavior, and psychological status should also be assessed. Now, pain may be accompanied by physiologic signs and symptoms, and there are no reliable objective markers of pain. The severity of pain can be assessed by using rating scales and the multidimensional scales. Now, the rating scales, which we're going to look at in a second here, provide a simple way to classify the intensity of pain and should be selected based on the patient's ability to communicate. Multidimensional scales, which is an example of it in your text is the McGill Pain Questionnaire, is helpful in obtaining information about the pain and impact on quality of life, but are more often time-consuming to complete. So we're going to look at the rating scales, which are probably used in your clinicals. There's a simple descriptive pain intensity scale, which goes from no pain to the worst possible pain. And the numeric scale, which starts out as 0, which is equivalent to no pain, to 10, which is the worst possible pain, and gradations from in between those two numbers. Then there's the visual analog scale. Usually this starts out 0 to a 100, and the patient is asked to mark on a line where they think their pain is at, from no pain to the worst pain imaginable. And kids usually respond best to the FACES scale, where there is no pain to where there's severe pain, which is 5. And then you have the verbal rating scale: no pain, moderate pain, severe pain, and the worst pain imaginable. And you can have the pain thermometer, which also rates pain. Now, the clinical presentation of pain in general, there usually is acute distress with traumatic pain, but there may be no noticeable suffering with chronic pain. Symptoms include sharp, dull, burning, shock-like, tingling, shooting, radiating, fluctuating in intensity, and varying in location. And nonspecific symptoms may be anxiety, depression, fatigue, insomnia, maybe even anger and fear. Now, acute pains are going to give you signs. You get hypertension, tachycardia, mydriasis, and pallor. With chronic pain, there may be no obvious pain signs in some acute cases and in most chronic persistent pain. And there are no laboratory tests. Pain is always subjective. It is diagnosed on a patient's description and history. Now, the goals of therapy are to decrease the subjective intensity, to reduce the duration of pain complaints, to decrease the potential for conversion of acute pain to chronic persistent pain syndromes, to decrease the physiological, psychological, and socioeconomic sequelae associated with undertreatment of pain, to minimize acute drug reactions and intolerance to pain management therapies, and really to improve patients' quality of life and ability to perform activities of daily living. Now, before we go on to the second part of this lecture, which is in video 2, we're going to just take a quick look at some non-pharmacological management, which involves the following approaches. There are physiotherapies that can help with pain, which include physiotherapy, occupational therapy, low-impact exercise, heat, cold, and massage. There's also psychological therapies that can be used, for example, prayer, meditation, imagery, and distraction. There are stimulation therapies, which include acupuncture and TENS units, and palliative care, which involves the alleviation of symptoms, but does not cure the disease. The next voiceover, which is part 2, will discuss the pharmacological management of pain.